Okay, we're great. We're ready to go. So welcome to everyone who's here in person, and to all of those of you who are joining us on the webcast. We appreciate it. I'm Louise Cohen. I'm the CEO of the Primary Care Development Corporation. For those of you who aren't already familiar with PCDC, we're a national not-for-profit and a community development financial institution established in 1993. So we're in our 30th year, and what we've been doing over that time is we were established as a public-private partnership to increase access to high-quality primary care in communities that have historically not had access to primary care, including rural communities, low-income communities of color. We provide targeted investment and expertise. We also advocate for policies that increase access to primary care, and we advance health equity and have a technical assistance practice. And there's a lot of folks here today from PCDC, so if you don't know us, please find someone with a PCDC badge and say hello. So this is the latest in a series of events that PCDC holds on an annual basis to bring experts together to talk about the key primary care issues of the day. And this year we're focusing on sexual and reproductive health. It's a big topic, and we're focusing today on the intersection between primary care and reproductive health. We believe that reproductive health care is an essential component of primary care. We think, however, that there remain many, many barriers to universally being able to access good reproductive health care in a primary care setting for a whole host of reasons that we're going to talk about today. So we hope you leave this summit with ideas about how you can work to make needed changes for yourself, your institution, your patients, and your community. So let's get started. I'm going to do the introductions, and then I'll turn it over to our panelists. So first I want to introduce Chelsea Faso. She is a physician, a family physician, who grew up in, trained in, and now works in New York City as a primary care family physician and is a dedicated advocate for sexual and reproductive access in primary care. Second, we have Teresa Lovelady, who is a social worker and has an MBA. She was a patient, then a consumer advocate, and now president and CEO of Health Corps, which opened in the 1990s and which currently is a federally qualified health center in Wichita, Kansas, and she has been a financing partner of PCDC since 2016. We helped them do the work to renovate and expand their facility. And finally, Kimberly Potter, who is a social worker and a public health practitioner. She's the vice president of practice transformation at Upstream USA, which is an organization working with health centers and others to strengthen reproductive care and autonomy by increasing equitable access to the full range of contraceptive options. And their motto on their Twitter feed, I thought maybe would set the stage for today. It says, "Every patient, every method, every door, without cost, bias, or coercion." So I'm going to turn it over now to Cynthia Summers, who is the managing director for our Strategy and Public Affairs Unit at PCDC, who oversees our policy communications, advocacy, and evaluation work, and who has a great deal of experience in this sector. So I welcome you all and thank you for coming today.
Thanks, Louise, and thanks again to everyone who's here in person, who's here on Zoom, and especially to our three panelists who have taken time away from their important work to be here with us for this discussion today. And as Louise mentioned, PCDC strongly believes that sexual and reproductive health care is an essential component of primary care. However, it often gets siloed and separated from mainstream primary care, even politicized, which forces individuals to seek out those services at standalone clinics. And so in June, when the Supreme Court overturned Roe v. Wade, ruling that there is no constitutional right to abortion, they at the same time created an access crisis. As of December, abortion services are completely unavailable in 14 states, and clinics across the US have closed, eliminating access to not just abortion services, but also to many other services that those clinics used to provide to their patients: contraceptive care, miscarriage care, cancer screenings, and many others. And even in states where abortion services are still available, the influx of patients from states with severe restrictions has created a situation where clinics are overwhelmed and patients are facing exceedingly long wait times. And as usual, the impact of these changes is being felt most by those who already struggle to access healthcare: low-income and underserved communities and communities of color. And so at this critical time, we wanted to bring together providers and experts to talk about what they're experiencing and to collectively think about the potential role that primary care can play in protecting and even expanding access to sexual and reproductive health care services for all individuals in all parts of our country. So with that, I'm going to open it up to our three panelists and start off the discussion with, as primary care advocates and providers, we talk a lot about the importance of integrated or whole person care. So in your perspectives, I'd love to hear what the successful integration of reproductive health care and primary care looks like.
Yep. Right. Yeah. Thank you. So I think one perspective to kind of hone in on is that primary care is really an access point into healthcare in our imperfect system, but the system that we currently use to deliver healthcare. And we know that reproductive health services, contraceptive care, abortion care, miscarriage care, they're time sensitive. These are things that are essential, and it's important to kind of address these needs in a time sensitive manner. And we do have the opportunity in primary care to, at that point of access, bring someone to the table and really explore with long-term relationships, what are your needs? What can our clinic, what can our providers, what can our support team offer? And a lot of times it is very valuable to be able to say, whatever you need, we can provide this. We don't have to kind of go along the trail of the story that's old as time. Let's put in a referral and hope that you get to see a specialist in the next 6 to 12 months, best case scenario. We know that you took maybe time off today to come to our visit, and you took the time to arrange childcare for your little one. And this is an access point, and really being able to provide everything that we can here to be almost sort of like a Swiss Army knife. Like, what do you need? What can we provide? How can we support? How can we provide you care, make you feel supported, make you not feel judged? And in a way, like in primary care, we have this luxury. We get to build long-standing relationships with patients. So there's no way we can ever really understand every piece, every part of someone's life that weighs into a decision, but we have glimpses, and maybe we can develop those relationships and build a trust with the patient to kind of be able to support a person in any decision, and really being able to offer that care to whatever a person needs in that moment in time, I think is beyond valuable.
Yeah. I think, Dr. Faso, you make an excellent point there, that being able to have access to care within a primary care setting is critical. What I love about a community health center setting is that our patients, no matter what your income level is, no matter what your insurance status is, no matter if you're uninsured, underinsured, no matter what you have, no one's turned away. So when we talk about access to sexual and reproductive health for the individuals across our country who are sometimes forgotten or left behind, they have the opportunity to come in and build a relationship with a provider and have that understanding that they could talk about anything and everything. In an environment, not only do they have access to medical services, but they also have access to behavioral health services. And I think there's a huge gap of opportunities when we talk about sexual and reproductive health. We focus on the medical side and we forget about the behavioral health side of sexual and reproductive health. So in our community health center settings, we have the opportunity to not only integrate medical, but the behavioral health and pharmacy and dental and other enabling services such as transportation, food pantries, just so many other things that are very relevant to serving these underserved and yet deserving communities across our country. So I really do appreciate the opportunity to be able to integrate, being able to have those open conversations around sexual and reproductive health in an environment that's trusted, because we know that there are a lot of issues around trust or mistrust within the healthcare system for certain communities across our country.
Yeah, and I think the point of, to the point earlier that there may be a lot of places where people don't feel comfortable going anymore, and if there are standalone clinics providing reproductive health care, those patients may not be showing up there. They may be showing up in these federally qualified health centers, community-based health centers, for other reasons, and can be kind of brought in to make decisions about their reproductive health care. And to Chelsea's point, this is a long-term conversation. People's decisions around whether or not to start a family, when to start a family, the size of that family will change over their lifetime. So this is really an ongoing conversation that you can have with patients and really helping them to figure out what's best for them in that moment, which again can change. And I think building a trusting relationship, understanding what's really important for your patient, their family, their behavioral health issues. So really looking at a whole person and ensuring that patients can have that autonomy to make that decision and have the resources and access to the tools they need.
Absolutely. And, Teresa, you talked about the community health center setting and how no one is turned away. And in this country in particular, the racial disparities in maternal mortality and infant mortality, particularly for Black women, are dramatic and stark, to say the least. And I'm wondering if you think that the successful and full integration of sexual and reproductive health care into primary care can help chip away at those disparities at all? And if so, how and what does that look like?
Oh my, okay. First of all, integrating anything in a community health center is not going to reduce systematic and institutionalized racism and other things that negatively impact the maternal mortality and infant mortality rates for babies and women that look like me. That's just the reality of the situation. There are many other things that impact maternal mortality and the infant mortality rates in our country. Starting with, there's good Lord. I can't even unpack that right here, right now, because there are just so many different layers and layers and layers of things that happen within our healthcare system and other systems of care that just wraps around healthcare from social determinants of health. We start looking at those factors. We start looking at trust and mistrust in the healthcare system. We look at medical provider education. We look at just institutions that just racism, I'll just put it there, institutionalized racism. And I believe when we start treating each other better as individuals and human beings, we'll start chipping away at a lot of different things that disproportionately impact a lot of people and a lot of issues. That's the overarching thing. But when we talk about integrating sexual and reproductive health in a healthcare setting, I'll just give you my personal example. I started out at my clinic as a patient, an uninsured patient, actually. When I became pregnant with my son, that's not how I started there, but when I became pregnant with my 11-year-old, I was very fortunate with being a patient in a community health center that there was an OBGYN within that setting. So I was able to just kind of work with the OBGYN or be referred in-house to the OBGYN and not have to wait long for a referral. And regardless if I had insurance or not, I was able to get over to Dr. Augustin and see him for my care there. I also, you're just able to do that when you're in a community health center setting. And I didn't have to worry about it being referred out if I was going to be able to get on state Medicaid and or if I was going to be able to get insurance and or if the referring provider was going to accept me regardless of my ability to pay. Can you imagine the fear of being pregnant and not having insurance and having to negotiate a system in a world with something growing inside of you and you don't even know what you're going to do and how you're going to do it and how you're going to provide or what you're going to do? I mean, that's just mission impossible. So being able to have integrated care within a primary care setting is so helpful, and it just reduces the need to increase access for care, where a lot of times it won't exist for certain segments of our population. I don't care what you do if you don't help other parts of our system when we talk about access to health insurance and access to other things. And we're not even going to talk about undocumented individuals who will never have access to state-funded programs if they do become pregnant. So there's a lot of different things within our system that we truly have to look at before we start looking at how do we remove or decrease disparities in our healthcare system and how do we move the needle on infant mortality rates or maternal mortality rates without truly addressing just a lot of different issues within our system.
Yeah, Teresa, you kind of captured it well at the beginning. I think the disparities that we see in maternal health outcomes it's an incredibly complex and complicated situation that's going to require a very complex solution. And I think, access to sexual and reproductive health services in primary care can be a piece of that puzzle. Will it solve the whole thing? Absolutely not. But really helping patients, again, to start to plan their families, thinking about the whole patient who may have some other co-occurring health issues that could really make a pregnancy complicated, and really helping them think about planning for the healthiest pregnancy that's possible for that patient. I think there's also a conversation that can start to be had around bias and coercion when you start to integrate sexual and reproductive health services that isn't often always had in a healthcare setting, where we know that we may be valuing some mothers over others, some pregnancies over others, and really starting to challenge providers to have a conversation of what biases are they bringing in to the conversations they're having with patients around contraception, building a family, deciding to have a child, deciding to have a short interval pregnancy, if that's what the patient wants. So really starting to kind of peel back the layers and encourage some of these difficult conversations, which will not solve racism that's inherent in our healthcare system, but I think really starting to expose it and allow people to start to have really difficult conversations that I think we need to have before we can start to address it.
Yeah, that's perfect. And I think to piggyback off the idea of how are we going to reflect on the services that we provide and the way that we are providing our care, because just to echo again, where we're not in the moment to find a quick fix. This is really, I think, asking ourselves what are the pieces that we could put into play to move change in the right direction in the capacity that we have. And certainly I see that one thing we can do is when we're implementing services, carrying out services, providing services for sexual and reproductive health care, kind of really using like this lens through reproductive justice, and not saying that I am a reproductive justice expert, knowing that that was a movement founded by Black feminists in the 90s, and this is a lens we can use to help us really center our efforts, really centering around the folks who are going to be most impacted by care. So exactly what we're talking about. So Black, Indigenous, people of color, folks who are seeking these services, really being centered in the efforts, and finding what are the ways in which we deliver services that can promote reproductive autonomy. How can we provide services in a way that really help folks reach a point of like reproductive liberation? Like, how can we make sure that there's access, that there's true choice, not just the right, because rights won't always provide equal choices for everyone. So how are we guiding these services to really centering folks who are the most impacted? Again, I don't think it's going to be the fix, but if we're looking through this lens, I think we can continue to make sure we're moving the needle in the right direction.
And I do think, Cynthia, I like kind of the reflection there, making certain that we create medical environments that are safe. I think that's one thing when I reflect back, where a patient feels safe to come into that environment, and safe in that exam room to have whatever conversation they feel like they need to have with that provider. That I think that's very important when we talk about the integration of sexual and reproductive rights. And so whatever that looks like for whatever primary care setting you're in, making certain that there's safety there.
Yeah, and I think both of you touched on the fact that in a primary care setting, when it's working right, there's trust that's built there, and there's a relationship that occurs and grows over a span of many years. And so if sexual and reproductive health services are integrated into that, it's not being thrown into a new setting with all new people, but it's entering a different phase or moment in a relationship that already exists.
I think it's an opportunity to help redefine the goals of reproductive health care. I think often, what I hear sometimes is like, well, my goal of contraceptive counseling is to ensure my patient chooses a method, that they walk out the door with what they get. And I think it's so much more complex and nuanced than that, to say, like, really our goal is to understand our patients, what's important to them, what's going to help them meet with their desires, their kind of goals for building a family. And I think, that relationship you get to build really allows you to have that conversation over time, and really allows it to sort of blossom and say, like, it's not to get them to walk out the door today with a method. It's really to ensure that I'm understanding what they're telling me. They feel safe to come back, and they know that this is a place that I can help them meet their goals.
Yeah, thank you. All of you are here with different backgrounds from different places, with different lenses. In your experiences, what have been the barriers to integrating reproductive health into primary care? Specifically, for example, when you think about providing the full range of contraceptive options and counseling to your patients in the primary care setting, when you think about being able to offer abortion services in the primary care setting, and all of the other parts of SRH involved, what have been the key barriers that you've encountered or seen?
Yeah, do you want? I can jump in. Okay. I think they really kind of run the gamut of kind of people, processes, and systems. I think, ensuring that people are trained, and I think that's from providers who are trained to counsel provide really good patient-centered, free of coercion counseling, and then, you're able to offer the full range of methods. Having providers on site who are trained to place and remove IUDs and implants, but also providers who feel really comfortable scripting out methods and making sure patients know about all their options. I think integrating a really strong contraceptive care workflow, so being able to ask a screening question, whether that's pregnancy intention screening or asking patients about their desires around parenting and if they want to have more children, or asking about a self-identified need for contraception, just being able to kind of pull that into like a routine screening, and then being able to provide the counseling, and then ensuring that you're able to sort of deliver on that full range of methods. I think it's thinking about a team-based approach, because when we think of primary care, you have 15 minutes to see your provider, and starting that conversation in that 15 minutes is probably going to be really challenging, particularly if your patient's showing up for another reason. So really thinking about how to use your entire care team to kind of be a part of this care. And so we were talking a little bit earlier, really getting buy-in from everybody in the system and everybody who's touching the patient to make sure they feel like they are motivated to do this, they feel bought in, they understand what their role is, and ensuring that all patients kind of get that routine care. I can pause and let others sort of jump in with other barriers.
Right. I think I can see that being really an important step about the buy-in piece. And yes, we were chatting a little bit just about, I think everyone coming into work in a community health center and folks who are maybe more behind the scenes are going to interact with a patient at some point as they're processing their care. They're calling to make their appointment. Maybe someone in the billing department is going to be processing your coding for the visit. The prescriber, the pharmacist who's dispensing medications. And I think everyone comes with their own experiences, their own values. All of us do have to reflect on, how did we grow up thinking about what should a family look like, family size, what's the age, what are all these kind of visions that we had for care for families. And in kind of initiating new services, and I'm not so sure this is unique for sexual and reproductive health services, but for gender-affirming care, for like substance use treatment, like where do we kind of have like a unsettling feeling? Like where are we recognizing where are the places where we may be inserting our own biases into how we're providing care for a patient? And I think exploring that piece and really bringing everyone to the table for that piece as the initial step is going to be pretty key, because I think that's going to be a big place for barriers, where we're bringing in sort of our values. We have lots of input when it comes to policies, legal regulations, things that are impacting a patient's ability to access care. And so I think starting there and really like identifying like what are concerns, like what are opinions, can we identify barriers? Are there things that we can do on a piece of education? For example, if there's kind of concerns about providing medication abortion care, is that, can we kind of provide information to kind of dispel myths, regarding like the safety and how simplified it really can be. So like as an example, but really kind of bringing everyone to the table, whether it's in like a workshop or whether it's in an anonymous kind of attitude survey, figuring out how we can identify barriers there, because I think that's where they'll definitely come up.
I would say some of the challenges for integrating sexual and reproductive health. At Health Court Clinic, we're located in Wichita, Kansas, so not that close to Kansas City, closer to Oklahoma City for those of you, about 50 miles near the Oklahoma border. So just to give you kind of geographically where we're located. So sometimes it's we're right in the Bible Belt for those of you that, so sometimes it's very difficult to find providers that are unbiased enough to sit in the exam room and be open enough to be considerate enough for the patient's rights. We don't want to say rights, but for the patient's viewpoint, and to provide the patient with the education and information they need to make an informed decision. So sometimes when we're working in a community health center setting, it's very important that you make certain that the providers that you do hire and that you do empower to inform and work with the patient population has been vetted, I guess, and you can trust that they are going to be unbiased in that situation. As the CEO of a health center, I meet all of our providers, whether they're medical, dental, behavior health, it doesn't matter. If they're expected to go into an exam room with the patient, I'm the first patient. I want to talk with you. I want to sit with you. I want to make certain that I feel comfortable. And I always ask very interesting questions. And, so and sometimes it does throw people off. It's like, what, did she really ask me that? And yes, I will ask that question. I will ask if I was considering, something that they didn't, and you can almost tell after you've kind of walked with them, talked with them, had lunch with them, dinner with them, you can almost tell that one question that you could ask that might just push them a little bit towards the line. And how would you respond to that question as a patient, if I was your patient? And even if they respond in the way they should respond, right? It's going to have them thinking. And I've had a provider self-select. You know what? This is probably not going to be a good fit for me. And that's okay, because we want providers that we want a mutual fit. We want it to be a good fit for the provider and definitely a good fit for the patient. Because patients trust whoever has that white coat on the other side when they walk in that room, especially in a community health center setting. They're not going to go back and check your references. They're not going to go back and say, can I see your degree, your diploma? They're trusting that that community health center has credentialed and privileged, that's what we call it, each provider that steps into that room. So it's our responsibility, and we're accountable for making certain that every provider that steps in that room is someone that patient can trust. That's important. That's what every provider, but especially when we start talking about sexual and reproductive health. So that's one of the greatest challenges, is making certain that you have the right people in that white coat on the other side of that table, or staring down at that patient while they're laying on the table to make certain that patient is still empowered. Because without the patient, we could all go home. That's kind of my motto at Health Corps. We can go home. If the patient doesn't show up, everybody goes home. And so it's really about the community and the patients we serve. And so when we start looking at it from that perspective, I think that empowers us as organizations to do the work that we should do. And at Health Corps, I like to believe that we are a learning organization. And in that, we all work together to make certain that we're constantly trying to be more proactive instead of reactive to meet the needs of our community. So if you create an environment where I'm going to put this one out there, culturally diverse enough, and if you're not in a culturally diverse community, so first of all, your clinic should look like your community, should look like the people coming to get services from you. If that's not what your clinic looks like, something's a little wrong. But you could fix that. Just start recruiting some of your patients to do some things for you. But if you look within your organization and you have that level of diversity, then you're able to have those conversations within your organization. So you feel like you could start talking about having those open and honest conversations, not only about sexual and reproductive health, but about any topic that comes up. Like when Black Lives Matter came up in our organization, we were able to openly have those conversations. So if you create a culture, a learning culture, I like to call it, within your organization where you can be responsive and proactive to different issues, then you create an environment where you can overcome many challenges that may impact us in community health centers and in primary care.
I'd love to shift gears a little, and this will probably be right up your alley, Teresa, as we talked before. Honestly, the money and the reimbursement is a big challenge, and it needs to be there. If services aren't being reimbursed, it's hard for health centers to continue to provide that care. And, I think We talk about FQHCs and community health centers that are really mission aligned, and they want to do what's right for their patients, and they want to provide access to that full range. But there are a lot of financial challenges to do so. And I think those range, across the US. We think about patients who are uninsured, underinsured, what sort of state-based programs are there to kind of supplement? Are there family planning programs? There are Medicaid waivers, there are Title X services. I think these have a huge impact in the range of services that health centers are able to provide. I think as we start talking about sort of those highly effective methods, IUDs and implants, and ensuring that patients have the access to the full range, those are really difficult to provide through health centers, to stock, have on the shelf, have available for patients when they show up if that's what they want. So I think it's really a conversation around, just the payer landscape and really what's available to patients.
Yeah, I know in Kansas, I think maybe January 1 of this year, they extended the ability for you to stay on Medicaid for 1 year after you have your baby. Previously, it was 6 weeks. So could you imagine at your 6-week checkup after you had a baby, you had to get so much done, or else that's it. And we're not even talking about, some behavioral health support or anything after that. So you have women who are trying to make it to that 6-week appointment. And at that 6-week appointment, you had to make all these decisions at one time. But during that 6 weeks, remember, you just had a baby. So your baby has to go to the doctor week 2, week 4, week 6. Your baby is a new baby, has a lot of needs, and so just mission impossible almost. So to be able to look at how our different payer systems work to make certain that those resources are available to women and families, to make certain that we can provide those services not at a loss. I'll put it that way, because it's the right thing to do. So we always figure out how to do it, and yet it is very difficult when you think about it financially, to really help and support women if they want to make some of the changes, take advantage of some of the opportunities, especially with some of the contraceptives that's available, because they could get pretty pricey and expensive.
Yeah. And I think it's, it should be surprising to hear, that network and that those available resources are different. Every state is different, and really, working with health centers as we do at Upstream that are across the U.S., it's really having to dig in there and figure out what's available to each health center. And it is complicated, and often health centers don't have the time to figure it out. And then it's making sure everything is coded properly and that reimbursement is matching, what has been sort of billed. And it can take a lot of staff time and resources just to dig in there. Go ahead.
At HealthCore, we've just purchased the product and provide it to our patients because it is extremely complicated, and yet it's more complicated if you have an unexpected pregnancy.
Yeah.
Because a lot of times our women will end up off of insurance, but because they're still in our primary care setting, they end up with another unexpected pregnancy. So that cycle goes on and on and on and on. And so to be able to provide that level of trust and level of access to options and opportunities, it's the responsible thing to do if you can do it. But it's also, again, trying to be as proactive as possible to serve our community is important. I have another option I want to throw out there. I know. When we were talking about sexual and reproductive health, sometimes we always focus on the woman. And I know every guy is probably going to hate me for this one right now, so I'm going to clench for the hate that's probably going to come. We always focus on women, and I feel like women bear the burden of sexual and reproductive health, right? But what happened to men's reproductive health? How come we don't talk about options and opportunity for men? So there is I call it the V word, right? Vasectomy. How come we're not educating in our community health centers and just making more available vasectomies for men? And I can probably understand why. Most men are probably going to be less likely to want a vasectomy. It's funny, I spoke with a partner and a peer, and a couple of other people. I did my own research. I did technical research, but then I also talked to a few people as well, because there's about 500,000 vasectomies performed each year. Did you know that urologists, that's their number one service provided by urologists? And yet, the number of minority men who get vasectomies are it's like 3.7% for African American men and about 4.5% for Hispanic males of all vasectomies that are done. Very, very low rates. And so I'm wondering, like, okay, the reversal of a vasectomy, first of all, the procedure, it's an outpatient procedure, 15 to 20 minutes, right, Dr. Faso? 15 to 20 minutes could be done in an outpatient, give a bag of frozen peas, 2 days recovery. You could get stitches, no stitches. I mean, it's like very basic surgery, not even real, well, I'm not even gonna call it real surgery, but it's very simple and basic compared to a tubal ligation, okay? Or tubal ligation, all right. So compared to that, it's very simple, okay? So if we had more men that were open to male reproductive health situations, I believe we could do things a little bit different. Like, it would look different in a community health center setting. A few years ago, we tried to integrate vasectomies at Health Core Clinic. I can tell you, we had a provider, he was all for it. He came in, he was willing to train and do all these different things to make certain that it was available. We were gonna be able to provide this service for like $200, which is lower than, this was like, wow, we could do this. I was so excited. It's like we did have a provider, she was ready to go, and I was like, seriously, you're gonna do? So, ready to go. But we missed a step on marketing, like who's ready to serve it up, right? Serve it up, get them in this. Actually, we had to get a different kind of, we were looking at like, what kind of chair do you need to put them in to do this? Like, can you put them? You get where I'm going here? You need a different kind of chair to put them in. So we're like gonna get this special chair, put them in, serve them up. Let's do this, right? We can do this. But I get that there is a lot of stigma and mistrust that we talked about earlier in the healthcare system. So it's one of those very basic procedures that a lot of minority men are less likely to accept because of fear. And because of, like, is it going to take away my manhood? Or, this is the one thing that I do have control over. And I don't want to feel like, what is it, that I haven't been well informed. I feel like we don't educate people enough about that as an option or opportunity. I also believe that we could do a better job at just education overall in our primary care setting, from abstinence all the way to abortion. I mean, the entire, like, what does that education look like? And in there is the opportunity when we talk about, we have parenting classes, we talk about motherhood, we put so much focus on there. But again, going back to men's reproductive health rights, talking about fatherhood and talking about fatherhood initiatives and pushing more on that. That peer I spoke with, he told me that when guys are given their sexual education, right, it's like, just don't get the first girl you do it with pregnant, pull out. And it's like, what? Is that what guys are being told compared to as a young girl? It's like something completely different. And I imagine, I have 5 sons and 2 daughters. And so what I told my daughter, like, the first thing is, like, as soon as she turned 16, it's like, let's get you on some birth control. I didn't do that with my sons. With my sons, it was a different conversation. So I think there are so many bias within ourselves and within our system when it comes to male and female reproductive, just those conversations we have about reproductive health. Right. I'll get off of that.
Wow.
But more vasectomies. Let's integrate vasectomies into primary care settings, so we don't have to worry about referrals to get that done. We can provide that access to care in a trusted environment where guys can get that done in a safe space and place with a trusted professional who's willing to give them their bag of peas and let them go home and watch football for the weekend.
I think that's fair. It's the full range of services. The full range. Were you going to say something, Dr. Foster? Okay. So shifting back a little bit to where I opened, that we, with the Dobbs decision in June, I'm wondering particularly for you, Teresa, and for you, Dr. Faso, if you have seen changes in demand, in access since then. I know you practice in New York City where we haven't been impacted. And I know at your community health center, you do provide abortion services.
Mm-hmm.
And Teresa, Kansas is a little bit different, not one of the worst, but it's a little bit different. But my understanding is your health center does not provide abortion services. I'm just wondering if either of you could talk a little bit about whether you've seen or heard any changes and how you are dealing with that.
Right. I mean, certainly. And I think changes, certainly going back to when the Texas Senate Bill 8 went into effect, the extreme 6-week abortion ban. So in the affiliates where I provide abortion care at our Planned Parenthood sites, certainly I think we were seeing folks traveling from Texas, Tennessee, Florida, folks who were just seeking out care because New York is a relatively easy place to travel to as far as availability of flights and different transit methods. So, and of course we are going to provide the care, and it's for folks who want to share. We do hear a little bit about what it took to get to that point, and you're seeing folks. I found out I was pregnant at 5 weeks, and I had an appointment here, and I couldn't get in care here. Then I had to raise the money to get on the flight, and by the time you're seeing them, maybe they're 15, later, and you're just hearing that journey. And certainly that has picked up after the Dobbs decision. I would say I saw my first patient in our community health center traveling from Texas for abortion care, and it's every person that I see that made it, it's always thinking about who didn't, and who, this is so much to muster up, to build the funds, to build the time in your life where you're, we know most folks who are seeking abortion care are already parents. And so how are we arranging childcare? How does someone take that journey? And it's hearing and always thinking about who is now going to be forced to continue their pregnancy, and that's dramatically going to change someone's life. So of course I think New York, and speaking for myself, understanding the role and being a surge area and wanting to kind of bolster up all the services to provide as much care for folks who are traveling from out of state. But also, that's not going to be enough because not everyone is going to have the luxury for traveling. And we know the folks who are not going to be able to travel are, again, going to be folks who are minoritized, folks who are living with lesser means. So always thinking about that.
Well, Health Court does not provide access to abortion services at all. It's very interesting. I know when Dr. Faso told me that they provided abortion services at a community health center, it's kind of oh my goodness, because there's, well, I don't want to unpack all that, but with federal funds, some of the federal funds that we receive, you're kind of pushed away, and you better not, how dare you, provide access to those services. So you almost have to have an ironcladded, something going on to be able to provide those services anyhow in a community health center setting. So, but I can tell you, because of where we're located there in the Midwest, not far from Texas and right there next to Oklahoma. There has been a lot more traffic up Highway 35 to get to the Kansas City and the Wichita area, to get to the few abortion clinics that are still remaining in Kansas, because with the defunding of Planned Parenthood a few years back and some of the other things that has happened, it's very restrictive. But I'm very proud to be a Kansan. I know we had one of the first votes across the country after the decision, and Kansas voted to not amend our Constitution, so abortion is still a legal right in the state of Kansas. And yet, it's still, I don't even know why it's political. That's a whole nother thing. I know we need to take politics out of healthcare at some point, but until then, we just do our very best with what we can in our community health center settings. So.
Well, great. So we have about 10 minutes left, and all of you have been really helpful in talking about some of the barriers and some of the needs. I think it would be really great to end this discussion looking forward and thinking about what primary care providers need to be better supported to be able to provide sexual and reproductive health services in their practices, in their clinics. And, Kimberly, you talked about the reimbursement issues and even the technical assistance surrounding all of that with billing and coding and stocking and things like that. And so both you, Kimberly, because you talk to so many different provider types in different states, but also to both of you who are on the ground more, is when you think about what primary care providers and the infrastructure in general needs to be able to take on sexual and reproductive health care as an integrated part of its practice. What does that look like? Are there policies that you run into that you see need to change? Is it, is it money? It's always money on some level. What else comes to mind? Is it training? Is it, you talked a little bit about the need to get everyone kind of on the same page from a values and a commitment perspective. And just thinking about, for all of us here and for everyone on Zoom, what can we all do to support primary care providers?
I'm happy to jump in. I think when we think primary care providers, I like to broaden it and think of like the whole system, the whole healthcare center, because it really is an initiative that involves everyone. And I think it is getting that groundswell and that sort of buy-in that this is something we want to do. And often with community-based health centers and FQHCs, they are mission aligned and they recognize this as like what we want to do for our patients. It's something we should be doing. And I think that takes it a step farther. And then I think it's looking at, the systems barriers that you're facing. And I think training is a big part of it. And I think it's, as I mentioned, training for providers around being able to provide both the education and the provision of that full range of methods. I think it's getting everybody in the system involved. We know that patients have a contact with numerous people when they show up at their health center, from the time they make their appointment to the time they get screened, roomed by an MA, to the time they see their provider. How do we utilize all those touch points to start identifying patient need early so that those conversations can happen, so that maybe provision can happen if that's what a patient wants? Because often we know if they step out your door and they didn't get what they need, they may not come back, or they may come back and they may already be pregnant. So really being able to identify sort of early on, I think, working with your billing and coding folks, understanding what the landscape looks like. What are your payers paying for? I do think, policies, particularly around FQHCs that are being reimbursed in sort of a per member payment, like one fee, carving out IUDs and implants from that, because they're really expensive and they're really hard to get stocked and get on the shelf to have them there, and to kind of recognize that if patients want that, it has to be reimbursed in a different way. I think it's kind of like looking at, the systems that you have, the infrastructure, the workflows. And Teresa, you said such a wonderful thing about your health center, that you're focused on learning. And I think, when we support some of our health center partners, I think recognizing it's a journey. It's really a process of getting sexual and reproductive health care integrated that could take a long time, and really starting, in a place that it already may be there, and sort of building off of that, and really kind of being kind with yourself and recognizing it's not going to happen tomorrow, but really keeping at it.
Right. And I think a piece, certainly, funding, I mean, it can always equate to more services. And I think another piece is bringing this as a understanding of, this is a standard of delivery of care. This is a standard of care. We should be able to provide these services. All folks should be able to access these services in their community health centers, and providing that idea that folks should be trained. We want to make this a core skill that providers have, that they can provide for patients. And I think, so just educational pieces around that too, language, forward-facing language, this is the face of primary care. We provide full spectrum reproductive services, and truly being integrative into that, and knowing that we really are hoping to provide whole person, person-centered care. So as we are kind of forward-facing and promoting these services, again, looking through our lenses, looking through how are we making sure we're not kind of practicing through coercive means, how are we best addressing the needs of patients.
I would thank you guys. I would also add that again, we're all human beings, and I can tell you, as the CEO of a health center, when all of this was unraveling, and just thinking about sexual reproductive health on top of COVID was still going on, and COVID was still going on, and COVID was still going on, and it's not one more thing, not one more thing. And I think too many times when we think about what we have to do in the primary care setting, and when we think about the community that we serve as a community health center, we're already serving some of the patients in some of the communities that are so underserved and so disadvantaged, and so, oh my goodness, you get that negative label, put it out there, that's that community, or someone in that community has that label. And so we think sometimes that on this really high level, it's the Dobbs decision. Well, that person who's striving and surviving to get to work and get food on the table and do all these different things, they're not worried about that, because I can't be worried about that when I'm worried about how I'm going to feed my family, and how I'm going to get home, and how I'm going to do this, and I got all these other things going on. So that's a lot. That's a lot. And so I do believe in a community health center setting, we have the ability and the flexibility to create an integrated model of care that not only incorporates sexual and reproductive health and all the other types of medical health, but we also have behavioral health. And I just want to go back to sexual and reproductive health. There has to be a strong behavioral health piece, because when you deny a family, not just that woman, but a family, access to their reproductive health, rights or justice, whatever we want to call it, it's not just impacting that woman, it's impacting a family, it's impacting a grandmother, it's impacting a father, it's impacting an entire community. And then when we start getting really specific and start going, well, if it's rape, or if it's incest, or if it's this, and if it's that, and if it's this, who's gonna go after and identify all of that? So we've made things so complicated, for each other. So sometimes I think if we could just pull back and start looking at each other as human beings, and respect and love each other, and the dignity that we each should give each other, That's probably the most impactful and powerful thing. And in a community health center setting and in integrated care, if we could just start when someone comes in and treat them with compassion, love, and respect, that's where we start at HealthCore. So
I want to come to your health
one
clinic.
center of care, that's our thing, one center of care. Everyone's treated with love, respect, and compassion, regardless of why. Even if you come in, you make an appointment for a hug, we'll give you a hug. Those are free.
Again, I want to come to HealthCore. Well, thank you, all three of you, so much for sharing so much of your wisdom and your experiences and your insight. It's been just incredible for me. And thanks to everyone for coming. I think Louise is going to close us out.
I don't think there's a whole lot more to say. I really want to thank the panelists for coming and for those of you on our live stream, we thank you so much for attending. And there's a lot more to be said, and I think these folks can be found on the internet, and they have a lot of experience and expertise and training and thoughts about how you can work in your own setting to move this issue forward. So I want to thank all of you for doing that. And for those people who are here in our, we're welcome. We have some refreshments, and we welcome you all to stick around for a while and chat with our panelists and each other. And I think, share hugs, because clearly that's the main thing that we need to be doing. So thank you all. It was a great panel.